Hello, ladies and gentlemen. Welcome to Triple N Media. I am Dr. Nik Nikam. The topic is Clinical EKG book Miscellaneous Conditions. That is chapter 14. In this presentation, we are going to be covering only part of this. So this is part 1 of Miscellaneous Conditions. So let us begin. We will be covering preoperative EKG evaluation, stress test EKG changes, low voltage, electrical alternates, hyperkalemia and hypokalemia. In part 2, we will cover the remaining segment in the miscellaneous chapter. So let us continue. Preoperative EKG. Thousands of people go through surgery in any city on any given day. And majority of these patients, especially if they are over the age of 40 or 50, or if they have heart conditions, they have preoperative EKGs. When you are evaluating a preoperative EKG, it is important to have a good understanding of what we see on the electrocardiogram, what has transpired in the past, and what could happen in the perioperative phase. So we have to keep those things in mind. Keeping that in mind, we look at the heart rate, we look at the heart rhythm, we look for any arrhythmias like atrial fibrillation, PACs or PVCs. So we need to check their electrolytes, potassium, magnesium. We also look for any evidence of previous infarcts, which may suggest the presence of long-standing history of coronary artery disease, coronary stents, blood thinners. So all these things come into play. Next, we look at any acute STT changes that may suggest an unstable situation which may need further evaluation before these patients go for any surgical procedure. Look for cardiac enlargement, which may add to the overall picture of the heart in terms of does this patient have heart failure? Does this patient have cardiomyopathy? Things like that. Also look for heart blocks. If these patients have more than second degree heart block, do they need a pacemaker? And what is their underlying cardiac condition? So reading EKG is, if it's normal, it's simple. It takes less than 30 seconds. But if there are multiple findings, you have to put all those findings together and see what is the risk of this patient going under general anesthesia. That's a pretty big question. So let us not take this for granted. Oh, I'm just reading a pre-op EKG, finished, go. No. If the patient has a pacemaker, that's going to make a whole lot of difference. What kind of pacemaker is this? Does the patient pacemaker need to be put on like a fixed rate? So it's better to get the pacemaker evaluated before this patient goes for surgery, especially if it's a major surgery, and the pacemaker may have to be programmed depending upon the type of the surgery. Are they going to be using cautery near the pacemaker battery site? Do you need to protect the pacemaker from getting these electrical signals from the electric cautery? And atrial fibrillation, if these patients are on atrial fibrillation or if they have coronary stents, they may be on blood thinners, and that's something I know when you're reading EKG, you're not concerned about it, but I'm trying to look at it as a holistic doctor, cardiologist, because those drugs have to be tapered off or held for several days before they can go for a major intra-abdominal surgery or vascular surgery, things like that. So keep in mind that reading a pre-op EKG is like evaluating a whole patient. The patient is not in front of you, but the EKG is a mirror image of what has happened to the patient's heart in the past, what it looks like now, and what could happen in the perioperative phase. Okay, talking about perioperative phase, there are going to be a lot of electrolyte imbalances. You can see hypokalemia or hypomagnesemia, things like that, that can cause STT changes or maybe even arrhythmias. Then there may be occurrence of atrial fibrillation with rapid rate, which is fairly commonly seen in perioperative patients. It's not uncommon for people to come into the recovery room and, I got chest pain, and next thing you know, you got a STEMI. I have seen these things in practice. So keep in mind that an electrocardiogram tells you a lot of stuff, but it may not tell you the whole story. But you need to extract as much as you can so that it is safe for the patient to go through general anesthesia. Okay, so much for preoperative EKG evaluation. So let's move on to the next topic, and that is common causes of low QRS voltage on an electrocardiogram. Very frequently we see these EKG changes such as low voltage when it's less than 5 millimeters in the limb leads and 7 millimeters in the chest leads. It's considered low voltage. When you are looking at low voltage, there are a number of conditions that can cause low voltage, like hypothyroidism, pericardial effusion, pneumothorax, infiltrative heart disease, amyloid heart disease, lead misplacement. Yeah, if you have a dextrocardia, you're going to have low voltage on the left side. Improper voltage gain. Here it should be like 10 millimeters, and if it's half standard, you're going to see low voltage. Standardization. Digitalis can cause low voltage. So it's very hard to find out, what exactly is causing low voltage, but hypothyroidism is a very common cause for low voltage. COPD, severe COPD can cause low voltage. And patients with pericardial effusion, of course, can have these things. So whenever we see this, we need to pay attention to what are the underlying medical conditions. Again, you have to remember that along with low voltage, we can see so many other things like U waves or STT changes or changes in the PR interval and the amplitude of the P wave, along with many other things. All right, now here let's look at an EKG. Can you make a diagnosis of what you're seeing? Don't read the top one, but anyway, if you look at this QRS voltage is different from this one is different from this one, and in the chest leads it's much more prominent. What we are seeing here is an electrical alternance, that is an increase in voltage in one lead alternating with a decrease in voltage in the other lead, and it is like a By-Gemini type of alternance. This is frequently seen in patients with pericardial effusion or pericardial tamponade. It can also be seen in patients with pneumothorax. It is seen in patients with infiltrative heart disease such as amyloid. So the most common causes are pericardial effusion, and the electrical alternance is seen more frequently in the precordial leads. Let's move on to, we see electrical alternance, and we also have what is known as the pulse alternance. Electrical alternance reflects the electrical activity in the heart as the heart is swinging back and forth in a patient with large pericardial effusion or cardiac tamponade. Whereas pulsus alternans refers to the pulse volume with each heartbeat. And of course, electrical alternans and pulsus alternans can coexist in a patient with large pericardial effusion or tamponade. So look for these changes in the pulse. If you have an arterial line, it's pretty easy to monitor this. And as I said, this can coexist in patients with the cardiac tamponade. What is your diagnosis? These are individual leads, and there are some numbers also there. This is a chart which will tell you a lot of information about what is the level of the potassium and what kind of EKG changes you expect to see. And there could be several questions on your board exams in relationship to the EKG changes, and they may expect you to guess the range of the potassium level. So let's pay attention. When the potassium level is 2.8, then you may see the flattening of the T wave. Similarly, the T wave becomes flat. When it gets to 2.0, we have a biphasic T wave. Then when it is, then we have a drop in the J point, then a biphasic T wave. Whereas on the other hand, you can also see prominent U waves in patients with hypokalemia. There could also be PR depression in patients with hypokalemia. In patients with hypokalemia, the QRS complex is generally narrow. It is not distorted as it is in patients with hyperkalemia. So pay attention to the T waves, U waves, ST segments, and the PR interval when we are dealing with hypokalemia. Let's switch gears and look at hyperkalemia. And you have to remember at what level are we seeing all these changes. If it is 1.7, you're looking like a biphasic T wave. If it's 2.5, which is a sort of mild, and you may see like just flattening of the T waves. And if it's 2.8, which is the lower limit of normal, you may just see a prominent U wave. So let's move on to hyperkalemia. The first change we're going to see will be tall peaked T waves, and it may be up to from 5 millimeters all the way up to 20 millimeters of tall peak T waves with a ST segment that is normal. And this has to be differentiated from an acute myocardial injury where the ST segment is lifted from the baseline, and from there the T wave takes off like a tombstone. So that's a different scenario. And when the potassium level is 6.5, when the potassium gets to 7.0, you see this J point depression and then a steep T wave, and there may be some widening of the QRS complex. When it gets to 8, you are beginning to see a widening of the QRS complex. So if you see widening of the QRS complex and they give you different serum potassium levels, think about 8 milliequivalents per liter. And if you see a sine wave like this, you're looking at potassium levels of 9.0, somebody who needs a dialysis to get the potassium level down. So always remember, they may ask you questions based on serum level of 7, 8, or 9, and have you guess based on the surface electrocardiogram what most likely is the level of serum potassium, and that reflects the gravity of situation as to how quickly we need to bring the potassium level down. Talked about hypokalemia, we talked about hyperkalemia, and these subtle EKG changes. Let's move on to, and what is your diagnosis here? And okay, we are seeing tall peaked T waves, and there is some ST elevation, but that's not significant enough. But the thing is, it is like 20 millimeters of tall peaked T waves. So this is going back to this chart, we are looking at like serum potassium level of 7 or something like that. Because if you had a widening of the QRS complex with a broad base, then you're going to be looking at something like this, where the serum potassium level could be 8.0. Okay, here we have a hyperkalemia, which could be ranging from anywhere from 6 to 7. So that's something that needs immediate medical attention. Okay, here's an example of a patient with a wide QRS complex and tall T waves. And this is a patient with hyperkalemia whose serum potassium level could be close to 8 or more. Because if you look at the tracings I showed you, okay, here is the tracing, and you can see you have a sine wave. And when you see that sine wave, we're looking at greater than 8 or 9. And this is a medical emergency. This patient needs dialysis because all the conventional methods may not help to bring the serum potassium level as quickly as we need it to come down. All right, treatment for hyperkalemia. Hyperkalemia, as I said, it could be mild hyperkalemia, which can be treated with simple things like diuretics and potassium sparing resins. But we have to remember that calcium gluconate can be used to bring the serum potassium level. We can also use insulin and glucose. Sodium bicarbonate is another option we have. Then we have beta-2 agonists, which can help to bring the potassium level down. Diuretics, of course, they work, and they work fine, but none of these will bring the potassium level as quickly as like a calcium exchange polymer or even hemodialysis. We have hemodialysis, and there's another one, Petiromer, which is a new agent. So there are various options available, but it all depends upon how quickly we want to bring the serum level down. And if it's a renal patient and who is already on dialysis, the best thing would be to do an emergency dialysis and bring the serum level down. Okay, here is a chart which looks at a lot of these agents we were talking about, like calcium gluconate, insulin, albuterol, furosemide, bicarbonate, and petiromer, all these things which can be used, and it depends upon the overall condition, cardiac rhythm, EKG changes, and the serum potassium level, and also magnesium level. Okay, let's move on to the next, all this stuff. Hypokalemia EKG changes. We saw these EKG changes based upon 1.7 level all the way to 2.8. As you can see, we can see an increased height and width of the P waves. We don't see it here, but that's something you need to keep in mind. We can see a P or prolongation in patients with hypokalemia. Just watch for those. The T waves can be flattened, as we can see the T wave flattening here, and the ST depression. So sometimes we can see ST depression as we see in these leads. And prominent U waves is a common feature of hypokalemia. And of course, when the potassium level is down, that's what usually you get called from a nurse, because this patient is having a lot of PVCs, and they call you and you say, okay, let's check the potassium and magnesium, and then you notice the potassium is 2.4. Hypokalemia precipitates with ectopic beats, both supraventricular and ventricular. And of course, if you see T and U waves blending together, it may give you a sign of a prolonged QT intervals. So that's something we have to keep in mind. Hypokalemia can also precipitate atrial flutter or fibrillation, and we talked about the ventricular ectopic beats. Hypokalemia can be seen in a variety of conditions, and the main thing is to recognize what is the underlying cardiac condition, and it can be seen frequently in patients with hypothyroidism, pericardial effusion, pneumothorax, infiltrative heart disease such as amyloid, we talked about, lead misplacement, voltage gain, and of course digitalis effect. And here is an example of a patient with an EKG showing a prominent U waves, and there's the next P wave. Along with that, we have some ST changes here, and the potassium level was 2.0. So, and there's some low voltage, and we can't say about the PR interval unless you have an EKG before the serum potassium level was wild. And when the T and the P wave blend together, sometimes it may be difficult. They could be having only one top, and that can give us an abnormal prolonged QT interval. So keep that in mind. Okay, ladies and gentlemen, this is a quick overview of miscellaneous conditions, preoperative EKG, stress EKG changes. One thing I wanted to tell you about stress EKG changes is that the stress EKG changes are most relevant in patients who are on a treadmill exercise test, who reach 85% or greater heart rate, because those EKG changes are not reliable in patients who go through dobutamine exercise stress test or regadenoson exercise test, or even a bicycle exercise test, because they have to be able to reach the target heart rate, the target MET levels, in order for the changes to be significant. Along with that, we also look for how quickly the changes, how significant is the ST depression. Is it 2 millimeters or is it 5 millimeters? And how long it takes for these ST segments to return to the baseline. What was the blood pressure? Did they develop hypotension? And did they develop any arrhythmias like atrial fibrillation? And I have seen patients who have developed ventricular tachycardia. So there are a whole host of things we pay attention to when we are doing a treadmill test. So we talked about low voltage electrical alternance, hyperkalemia and hypokalemia. And in part 2, we will be talking about calcium, magnesium, hypothermia, cardiac transplant, hyperthyroidism, and muscle tremors. And please do subscribe to our channel, and we will see you next time on Chapter 14, Miscellaneous Conditions, Part 2.